I want you all to help me by imagining a scene. We're in the urological outpatients department of a large London teaching hospital. It's running late, and a couple are waiting nervously in the waiting room. They've prepared by going to consult Dr. Google. Dr. Google, as is usually the case, has dispensed fear and confusion in equal measures. The consultant is clear that she has to give him bad news. She's been trained in how to deliver bad news some years ago now, but trained all the same. She's never received any training, though, in how to triangulate between patient, spouse, and herself. And she's conscious that she has to deliver that bad news in a matter of a few minutes. And then she has, if she's lucky, to effect a handover to her clinical nurse specialist, who may or may not be available at the moment when she's needed. Which of us would envy her that role? I asked that question at the start because I want to be clear that what we're asking of our healthcare professionals is a savagely difficult thing. And I will, over the course of the next 15 minutes or so, offer some challenges to the medical profession. That's why the fast car is waiting in St Andrew's Place. But I want to be absolutely clear at the start that the delivery of bad news, especially under those sort of circumstances, is a fantastically tough thing to do. The title of the lecture is intended to be as unattractive as possible, but you've still come in great numbers. I want to be clear that I'm not only going to talk about cancer, although that'll be my principal reference point. I think insofar as I've got a message to impart, it's one that copies across other serious conditions and indeed applies both to curative care and to palliative care, which, as Jane was saying, is at the heart of Marie Curie's concerns. And I want to talk not just about communication as the simple transaction of information between two or more individuals, but also to talk about that more subtle exchange of meanings, which may be verbal, it may be non-verbal. And increasingly, that's the realm in which we need to enter as we move into an era I welcome, of shared decision-making, where patients have to be engaged in the process of coming to a conclusion about what is best for them. So communication is our topic. And I want to look at it from two quite distinct angles. First of all, from my own. I want to share with you 5 stops on what I'm encouraged to call my cancer journey. We'll come to that in a moment. And then I want to stand back and say, to what extent can that experience be generalized? To what extent do we have a more general problem across the NHS? And if so, what can we do about it? And it is that second half of the lecture that is at the heart of the long and winding road. Now, let's begin with my own experience. And I thought it would be more entertaining in some ways if I didn't do this on my own, but I called on the help of 2 very dear friends. We're going to play out 5 of those scenes for you. And Chris Moore and Jeremy Vine are going to help me do so. They're both multi-talented. Chris, amongst her many talents, is, I'm told, expert in the Argentinian tango. Jeremy presents a daily program on Radio 2. Anyway, let's again begin at the beginning. Let's begin with the diagnosis. We're going to turn to a scene which took place in September of 2011. And I should say that with each of these scenes, they've been abbreviated for reasons of brevity. They've also been anonymized because they don't I don't want to make a point about a particular doctor or a particular hospital. But otherwise, they remain faithful to events that really happened. Now, I'd already had 2 sets of biopsies by this stage, but I hadn't had a diagnosis. I hadn't even met a doctor. And for those of you who aren't fellows of the Royal College, I'll do a bit of jargon busting as we go along. You'll hear mention in this scene of the Gleason score. That's the way in which prostate cancers are graded. You'll hear 2 numbers, add them together, and you get the score. The nearer that score gets to 10, the worse things are. So let's hear how I found out that I had cancer.
Come in. Ah, Mr. McDonald, have you decided yet whether you want to have it removed?
Well, what is my diagnosis?
Oh, didn't they give you the result? It's a Gleason score of 3+2.
So I have cancer?
Oh, yes. The only question is what you want to do about it.
And is a Gleason score of 3+2 good or bad?
Well, I wouldn't say it was good exactly. There are a number of treatment options available. There's the radical prostatectomy, which we do here using the laparoscopic robotic method. There's brachytherapy, there's radiotherapy, there's laser and HIFU, although both those 2 are still on trial. And then there's our old friend, watchful waiting. Now, the RP...
RP?
Radical prostatectomy. We use the Da Vinci robot here. That has dramatically reduced patient recovery times and also hospitalization. But, as with all surgery, there is some risk of damage to structures. In this case, neurovascular bundles, sphincter, rectum, and so on. I would hope to save the nerves on one or other side of the capsule, but there's still at least a 50% chance of ED.
ED?
Yes, erectile dysfunction. And then there's also incontinence. I mean, it shouldn't be too bad to begin with, but with your Parkinson's, it might be difficult later on. Anyway, the nurse will talk you through all of this. Any questions for now?
Well might he look despairingly to you. So my role here is to do the post-match analysis of these scenes. What did we make of the first one? It was chaos, really, wasn't it? We had treatment mentioned before diagnosis. Indeed, we had diagnosis eventually before the patient was even sedentary. There must surely be some GMC guidance somewhere about the need for a patient to be at least recumbent before diagnosis, isn't it? And then the doctor proceeds to run through this mystifying list of treatments, at least one of which sounded as though it was a Chinese martial art. Indeed, it might be, for all I know. You can imagine that I was left utterly perplexed by this exchange. I was somewhere between shock and fear by the time I stumbled out of the room. I did go to see a clinical nurse specialist. She indeed did take me through the various options. I remained perplexed. She sensed this, so she pressed harder. And she encouraged me to think more incisively by asking, Andrew, it's important that you think about your values. Would you do that for me? Well, I thought, but I still looked perplexed. So she said, to help things along, Andrew, what do you think about continence? What do you think about potency? I was tempted to say that in general terms I was in favour of both, but I felt that might have been missing the point somehow. But I had one thing on my side, I learned. because the urologist whom I saw shortly afterwards said, "Andrew, the great thing about prostate cancer." I thought, hang on, the great thing about prostate cancer is that it's never urgent. I took what comfort I could from this, and then, well, the process that you face when diagnosed with prostate cancer is a bit like descending into the bazaar. That's bizarre, not bizarre, although the adjective may be as relevant as the noun. Because you're faced with this whole series of possible options. I think I counted 6 or 7 in all. And it's a bit like having doctors as hawkers at stalls, summoning you over. Come my way, and I will cure you. Come my way, and I will cause less collateral damage than the next fellow. What is one to do, especially when the only question, certainly in my mind, was which one of you is most likely to keep me alive? But I did at least have time to consider the options. Or I did have time until the same urologist told me 4 weeks later that my PSA, that's the blood marker for prostate cancer, had gone through the roof and that it was now extremely urgent that I took a decision. I felt this period of greatness of prostate cancer had been rather exaggerated. And he further told me that most of the wares on sale in the bazaar were no longer available to me because of the urgency and because of the aggressive nature of my tumour. So I made a rapid purchase. I made a rapid purchase of a radical prostatectomy, the removal of the prostate gland. That seemed to me, on the basis of the evidence I'd heard, the best chance of my remaining alive. I could hardly say that it was a terribly considered process. So I had the operation. I had the operation in the spring of the following year, and in the next scene, you'll see me returning to find out the result of that operation. I go back to see the surgeon who performed it. Another bit of jargon busting for non-fellows. You'll hear reference to the word histology. It refers to the condition of organic tissues, and in this case, the organic tissues most in point are those which have been left behind after one hopes that the tumour has been removed. So let's meet the surgeon who performed the operation.
And how are you? Any problems down there?
Well, plenty.
No, let me just get your results. Here we are. No, just a moment. When were you born?
27th of the 6th, 62.
Oh. No, here we are.
And?
Well, that was really very high.
The Gleason score?
Yes. It was a 9.
No, it was a 5 and then a 6.
Really? Let me just check I've got the right one. What's your name?
Andrew McDonald.
And your address?
22 Acacia Avenue, N10.
No, this is you. We can never be sure until we take the thing out and then we retest the tumour, and it turned out to be a 9.
Which is as bad as it gets.
Pretty much, pretty much.
And the results?
I'm just looking now. Histology looks excellent, and the margins are all clear.
Right, so...
An exceptionally good result. I can't think of another department in the country that could get this result with a Gleason 9.
And the nerves?
Let me just see. Oh, they look good. Tickety-boo.
Miss Stringfellow, I don't know how to thank you enough. This is absolutely amazing. I'm actually very grateful.
Very good. So, from now on, your care will be in the hands of one of our oncologists, Dr. Szczepanik.
And, OK, Dr. Szczepanik, the oncologist. How do I spell that? Sorry.
Do you know, I don't know how to spell it myself. They'll tell you at reception on your way out.
OK, I'll ask there.
Very, very good.
So, what did we make of that one? I think I feel amongst some physicians in the room maybe a certain sense that surgeons have been nailed in this scene. It's certainly true that Stringfellow is rather full of herself. It might have been a good idea if she'd perhaps looked rather more at the patient than at the computer screen. Rather shocking that she wasn't sure she necessarily had the right patient in front of her till she was part way through. But not obviously a car crash. But of all the scenes we'll see this evening, this is the one that really is the car crash. Not because of what Stringfellow says, but of what she omits to say. I now know, but I didn't then, that there are two measures of whether or not a prostatectomy is successful. The first is indeed the histology, which was being discussed by Stringfellow. But the second is what happens to the PSA in a blood test that has to take place some weeks after the operation. Did you hear reference to the blood test? You did not. So I left that consultation elated. I had cheated just about the most aggressive form of prostate cancer. You can imagine how I felt some 4 weeks or so later on when I went to meet Szczepanik, the oncologist, for the first time, after I'd had the blood test taken. I didn't attach any particular importance to the blood test. You have blood tests when you go to see doctors. He had to tell me that not only had my PSA gone up rather than down after the operation, but it seemed to be breaking all known records. I'd moved from elation to something close to despair. So why didn't he mention it? We can't, of course, be definitive about the answer, but I think we've got some clues here as to why he failed to mention it. He is fantastically focused on his part of the treatment of the patient, his part in the healthcare chain. You see it, for example, in the astonishing fact that he can't even spell his colleague's name. This is a fellow consultant with whom Stringfellow has worked for a number of years, with whom he works in the same multidisciplinary team. Szczepanik has a room 2 doors up the same corridor from him. They have their clinics on the same afternoon. He doesn't know how to spell his name. What sort of team is that? What sort of team, indeed, is a multidisciplinary team in the clinical context? I'm sure that they're better than what was there before, but are they teams in the sense that the rest of us would recognize them? With clear leadership, with shared values, with clear objectives, where the junior member of the team has as much a right to speak as the most senior? I think it's at least reasonable to ask that question. Now, teams can exist in the context of clinical care. I've seen outstanding examples of teamwork in the course of my treatment. I think particularly of the radiotherapists who took me through 30 days of radiotherapy in the autumn of 2012. From the moment you stepped foot into that lead-lined basement and were greeted by Alice, the receptionist who regarded you as one of her patients, and she was going to help you through the next 30 days by counting down the days, by jollying you along, you were clear that you were in the embrace of a team which was focused on your care. And then on to meeting the radiotherapists themselves, who again took a common approach to the way in which they cared for me. And radiotherapy isn't painful, at least pelvic radiotherapy isn't painful, but it's a bore, and it's tiring. And they carried me through to the end of it. And I will always remember the last day of that treatment. I used to have the first appointment in the day so that I could then go into work afterwards. And on my last day, the sleepy-eyed Sunil, a marathon runner who never liked mornings, wasn't there because he was on an afternoon shift to do some training. I was sad about this because I wanted particularly to thank him because he'd been there all the way through. I had my treatment, I dressed, I came out, and there he was. He'd come in several hours earlier than he needed to, simply to wish me well and to bid me farewell. And I went to work that day not worn down by 30 days of radiotherapy, but buoyed up by the simple milk of human kindness and by the common ethos of that team. So it is perfectly possible for teams to exist in a clinical context. Equally, I believe, but I haven't seen this myself, it's possible, unlike the evidence we saw from Stringfellow, it is perfectly possible for that ideal of holistic care to be realized in practice. Whereas Stringfellow focuses on the treatment of certain organs, holistic care, of course, encourages the healthcare professional to look after the whole person. My own experience of this has been rather limited. I most directly encountered it, if that's the right word, when I had some problem with my alimentary canal after radiotherapy, and I had to go to the gastrointestinal department for some treatment. And on arrival, one is presented with a pro forma. The pro forma announces very firmly that this department is committed to holistic care. And to get a better sense of your needs, we would like you to complete this survey. This will enable us to get a better sense of your physical needs, your emotional needs, and even your spiritual needs. I thought this must be some form. Anyway, I duly filled it out. And on my return to the GI department the following month, I think it was, I was given the result. I was given a piece of paper which said that on the holistic care assessment scheme, I was a 6.6. Now, there was in small text, there was something saying that I could inquire further as to the significance of this number. But somehow I felt the point had gone by that stage, and I didn't bother. Anyway, back to Stringfellow. Not, I think, a practitioner of holistic care, and I suspect not a team worker either. Those, I think, are my principal conclusions on that episode. Now, I've been fortunate in very many aspects of the care I've received, and the technical care I've received has been uniformly excellent, and I want to stress that point. But one aspect of my good fortune has been continuity of care. I come back to that point in that initial scene I asked you to conjure up. How on earth can we imagine people to impart bad news when they haven't even met the person before? I've been lucky in having continuity of care, both because my cancer is particularly aggressive, but also because I have Parkinson's disease, and so it complicates the care somewhat. So for the most part, for the overwhelming majority of occasions, I've seen Schapanik. But things go awry when that continuity breaks down. And I want us now to look at one of the occasions when Schapanik is away and a registrar stands in for him. Let's listen in.
Hello, Mr. McDonald.
Yes.
So, I have good news for you. Your PSA is 4.2.
No, but that would mean it had doubled in the last quarter.
No, it is good news because you have not had a prostatectomy.
I have.
No, I don't think so. I mean the operation to remove the prostate gland.
I know what you mean. I had it in March 2011 and it was unsuccessful.
You did? Oh, my God. Excuse me a minute. I have to talk to a colleague.
Now, I don't know how long she was away for. Maybe 5 minutes? It felt like 50. But I was already absolutely clear that I had no faith in her at all, and that I wanted to see Shapanik as soon as it was possible to do so. But that determination couldn't wipe away the damage and confusion already caused by being told that I had a PSA of 4.2. Let's hear what happens when she comes back.
You are right. You have had a prostatectomy, March 2011, it says so here. And you are also right, this rise is not good news. You are correct.
Right. How bad is this?
This sort of result can be very, very fatal. I cannot say how long, months, maybe a year. I am sorry.
Well, you know you're in trouble when you're told that something is going to be very, very fatal. I don't think there's much I can do by way of post-match analysis here, in that this was so evidently a car crash. An ill-prepared doctor, and one who doesn't listen to what is said to her. Because after all, doctors, of course, have to filter the information they're given by patients. But in this case, we have a patient saying, an operation took place on this date, and this was the result. But she plows on until the position is irrecoverable. I've been enormously fortunate in having continuity of care, but I'm conscious that that is, for many, the exception rather than the rule. Continuity of care which allows doctor and patient to read the verbal and indeed the non-verbal cues that the other is giving off. Now, I said that I wanted to look at communication in the round, including written communication. And I want to turn to that next. Because after all, that's the way in which many of us receive a good deal of our information from doctors. In those rather curious letters that are sent to your GP about your health and copied to you, you might wonder why it isn't the other way around, but maybe that's for another evening. Anyway, in this case, we're going to listen in to a letter which was written in the early stages of radiotherapy treatment in the autumn of 2012. I was already beginning to struggle with fatigue, and a young registrar was writing to my GP. I think it's probably a good idea if we take it sentence by sentence. But don't worry, there are only 3 of them.
I saw this man...
Sorry. My apologies. I should have said that I thought it might help if I joined you for this. So if I may, I'll just sit here while you type. And I might add just at the start that we're not going to deal with that block of text at the top of these letters, that block of text which has one doctor speaking to another and describing the morbidity, the details of the disease itself. Because for the rest of us, frankly, they are completely incomprehensible. They might as well be written in Greek. Indeed, come to think of it, sometimes they are written in Greek. Anyway, we'll carry on.
I saw this man...
Don't mind me, you just press on.
I saw this man in clinic today after 9 days of radiation therapy.
First sentence seems innocuous enough, doesn't it? But what about that reference to this man? How have you generally been referred to in those letters? This gentleman? This lady? In my experience, doctors are pretty good at gender identification. If they're feeling really effusive, they might run to this charming gentleman, this charming lady. A bit more reserved, and they might throttle back to this patient. But this man? It's one doctor saying to another, "We didn't get on." Which is fair enough, because we didn't. Let's carry on.
He's experienced some grade 1 fatigue, urinary symptoms, and diarrhea.
Full disclosure this evening. Again, on the face of it, pretty straightforward. But what do we make of grade 1 fatigue? Is that the very Everest of exhaustion? Or does it mean I'm just feeling a bit peaky? I don't know which way around the scale works. And in any event, which of us got up this morning, felt a bit rotten, and said to our nearest and dearest, "Darling, I think I've got a touch of the grade 1s this morning"? I suspect nobody. Anyway, let's press on.
He continues to work for the Independent Parliamentary Standards Authority and also lives with Parkinson's disease. So his fatigue is no doubt multifactorial, and he himself has a good understanding of this.
Looks as though we'll finish there. Now, this is what is known in the jargon as the operative sentence. And there's a lot here. First of all, we have this wild reference to IPSA. Now, even MPs at their most excitable didn't regard employment by IPSA as a known medical condition. And we proceed to have this reference to living with Parkinson's disease. It's as though Parkinson's is some sort of exhausting floozy. If only, is all I know. But the nub of this comes in the final sentence, the final part of the sentence. So let's just, if we may, have that clause again.
His fatigue is no doubt multifactorial, and he himself has a good understanding of it.
There we are. Let me translate that for you. I have no idea what causes his fatigue, and frankly, it's not my responsibility, and it's not my specialism, and McDonald knows that. I think that's what's being said, but I think we'll leave it there. So, there we have an example of written communications. There are plenty better, but that, I think, illustrates at least one type of the genre. And what, of course, one has got there, and here there's a more important point to make, is a misalignment between the priority of the doctor and the priority of the patient. What patients want is to be well, or at least less unwell. All too often what doctors want to do is to treat the illness, and those are not necessarily the same thing at all. So if I'm saying, as I have said for the last 5 years, fatigue is the principal problem I have, I think it's reasonable to expect doctors to respond to that. Now, fatigue is very difficult to treat. It also can slip between specialisms very easily. But that misalignment in priorities, so evident in that communication, is, I think, one of the principal themes of my experience of treatment and of communication. It was captured very precisely for me when a doctor for whom I have a great deal of time was prescribing steroid treatment for me for the first time. And he ran through a long and indeed alarming list of side effects. And when he got to the end, I said, "I have a question." "Yes," he said. "I thought I knew that steroids cause the face to go round. You see, I focus on the really important issues. And he said in response, that's true in about 50% of cases. And with a smile of self-knowledge, he added, but of course we tell you the side effects that matter to us, not necessarily the ones that matter to you. It was said with self-knowledge, but it captures an important truth about medical treatment and medical communication. Now, we've had an opportunity at times to laugh at some of the scenes that we've played out. I want us to look now at what happens when the going gets tough. This is a scene from September 2013. I've had a scan, and I'm going back to get the results. One other bit of jargon busting. You'll hear reference to metastasis. Metastasis is the spread of cancer. Let's listen in to what happens when I go along to get the results.
So, Andrew, we've had the test results back.
What do they show?
They're not what we want to see.
Please tell me what they show.
This shows the cross-section of your pelvis, various sections starting low down and then rising. These coloured areas here show spread within the pelvis, but what's significant is these florid colorations here and here, which show spread to 2 lymph nodes above the pelvis.
So it's progressed up through the lymphatic system?
Yes, it has.
But we always thought there might be some metastasis?
Yes, we did. But what's really significant here is that it's escaped the pelvis. And I'm afraid that what this means is that it is now incurable.
Oh.
Andrew, I know that, as always, you'll want to know what this means for you. We are still talking years, but not many now.
So let's just stand back from that and consider what we've witnessed. We've witnessed an exchange between 2 people who've come to know one another over the preceding 2.5 years by the time of this meeting. 2 people who've come to like one another. 2 people who've come to understand how the other communicates, to pick up those verbal and non-verbal cues. And watch the way in which Szczepanik gently unfastens my fingers from the straws at which I grasp. And it was, of course, a longer conversation than the one we've shown you this evening. Bit by bit, he manages down my expectations. It was, in short, a masterclass in how to deliver bad news. It can be done. This is one of the many instances in which I've seen how it was done. Let's now, as we come to the end of the first half of the lecture, stand back and reflect on what those scenes have shown us. We've seen some of the best communication skills. We've seen some of the worst communication skills. But I think we've also picked up some clues which maybe have helped to us in the second half of the lecture. We've noted deficiencies around teamwork. More than a suspicion that the priorities of the patient are not being fully embraced by the medics. And we haven't seen a great deal of holistic care. Those are clues which I think we will pick up on as we turn to the second half of the lecture, where I want us to stand back and to ask ourselves 3 questions. First of all, is what I've experienced of more general application? Secondly, if we do have a problem, how big is it? And third, what might we do about it? And it's this analysis that is in the heart of a long and winding road. And here I happily acknowledge the brilliant work that Joseph Sherlock did as the principal researcher for this work. So, we've got those 3 questions. I thought we might begin with the first one. Do we have a problem across the NHS? Well, if we begin by looking at the survey evidence, 2 things are clear. The first is that there has been a notable improvement on many of the indicators of good communication over the last 15 years or so. It's important that we note that. The second is that some of the standards of communication remain simply unacceptable, at least to my mind. It is surely unacceptable that only 56% of cancer patients say that they have definitely had a discussion with their doctors about the possible side effects of their treatment. Just 56%. And only 22% say they have a care and assessment plan for their treatment. We do have a problem. And we have a problem which is evidenced in the quantitative data analysed more fully in the report. But also one sees it in all manner of qualitative evidence. Consider, for example, the remarkable campaign run by Dr. Kate Granger with her appeal to be treated as a person, not as a bed number. It's quite clear to me we have a problem, but how do we measure it? How do we get a sense of it? What sort of metrics are helpful? Well, one thing we can try and do is to monetize the problem, to give a sense of it in financial terms. How much money is wasted by poor communication? Now, there are various ways in which poor communication wastes money. For example, if a patient doesn't understand his or her medication regime and consequently doesn't complete the course of medication or takes the medication wrongly, waste ensues. If a patient comes back for another consultation because the communication first time round was inappropriate, as we saw in one of our scenes, you're taking up more hospital time than is appropriate. And as the Ombudsman pointed out in her report on end-of-life care last year, so many disputes in the NHS arise from poor communication. This year, in England alone, some £1.4 billion will be spent on the settlement of claims by patients. Now, obviously, not all of that arises from poor communication, but a fair share of it does. Now, I think it's telling that the NHS has not seen fit itself to work out what the total cost of poor communication each year amounts to. You would have thought if you really attached priority to communication, you might have done that sum. It was beyond our resources in the preparation of the paper to put a precise figure on it. But if you use a mixture of comparative data from overseas and data on the cost of wasted medication here or the cost of disputes, then it's clear, it seems to me, that the true cost of wasted communication in England every year is some way north of £1 billion. That alone seems a good enough reason to me to take this problem seriously. But we're not just talking about a matter of efficiency here. poor communication changes the way in which patients experience healthcare. Survey after survey tells us that. And more than that, the literature is now compelling that poor communication has an impact on health outcomes, on whether or not and how quickly people get better or not. If we care about anything in running a health service, surely we should care about that. So I'd maintain we do have a broader problem. And it's a problem which we have an obligation, it seems to me, to address. The good news, and there is good news, is that we have to hand many of the tools that we need to address this problem. And they're tools which have been tried and tested and evaluated, and in many cases proved to be cost-effective. That's to say that the initial investment repays itself over time. So we're not talking here about adding to the overall NHS budget in the long term. There is a clear spend-to-save case waiting to be made. What sort of tools am I talking about? Well, quite prosaically, training healthcare professionals to deliver bad news, to deal with families, to deal with situations which the rest of us would quail at. Training has now been evaluated in terms of its impact on the behavior of medics. It's been proved to have a positive impact. And yet we've turned off the funding, central funding for the advanced communication skills training. Another, and to my mind, very powerful tool is the use and further deployment of clinical nurse specialists. They can't sadly be conjured up overnight. And yes, I read this morning's headlines about a recruitment crisis in the NHS. But the evidence is compelling, not just in cancer, but across a wide range of conditions. Epilepsy, multiple sclerosis, Parkinson's, and so on. That clinical nurse specialists, first of all, can pay for themselves over time, but also have a profound impact on the experience of healthcare and on the experience of communication by patients. In the National Cancer Patient Experience Survey, the single indicator that correlates most closely with high scores from patients is whether or not a patient has been assigned a named clinical nurse specialist. And there are other tools, simpler, cheaper ones. The use, for example, of simple question sheets given out in the waiting room so that patients can think about them before they meet their doctor, so they can make the most productive use of those consultations. These tools already exist. So in many ways, I think the question we should be asking is, if they exist, if they're cost-effective, why hasn't this problem been solved by now? And here I want to offer you three, what should I call them? Provocations. I think the fast car is still waiting. The medical profession has for generations given preferment to those who are academically excellent and who have clinical expertise. Now, don't get me wrong, I'm all in favour of having brainy medics. I have several of them myself looking after me. But does it genuinely, when push comes to shove, attach the same importance to what are known rather misleadingly as soft skills as it does to those clinical skills or academic skills? I rather doubt it. Equally, I rather doubt whether the introduction of appraisals for medics or reaccreditation for consultants, whether those systems are sufficiently robust to encourage peers to call out those who are the weak communicators and to challenge them with their behaviours. So I think I have a question about whether the medical profession is really serious about this as a challenge. Secondly, I'll turn my sights to NHS managers. Cast your mind back to the opening scene with that harassed consultant with the clinic running late, knowing she has to land the bad news in a few minutes. Unless we get the logistics right, unless we provide doctors with the right context in which to conduct those conversations, then the savagely difficult, frankly, becomes impossible. We need to cover the hard yards in terms of rostering, in terms of ensuring at least some continuity of care, in terms of making sure that clinic lengths are reasonable. Let me just give you one small example of that. One of the best communicators I've encountered, a dermatologist who cared for my mother in her final months, wanted to be here this evening, but he couldn't, because his clinic has just been extended from 2 o'clock in the afternoon to 7:30 in the evening. Now, we might all feel daunted by delivering the sort of bad news I was discussing at the start, but just imagine doing it after 5.5 hours of clinic duration. We've got to get the logistics right. And my third challenge is really one for politicians, especially for Secretaries of State of Health. We need to stay the course. If you're trying to achieve cultural change of the sort we're talking about here in terms of improving quality of communication, if we're going to achieve that, we need to be willing to stick with an initiative. Whereas in practice, you can look back through the last 20, 30 years of official publications and see the same things written about communication, beginning with an Audit Commission report of 1993, which says we have a problem with communication in the health service. We need more training. Take it through to the cancer plan of 2000, from which many good things did genuinely come. But one of the things it said was we need advanced communication skills training for those who treat cancer. That training was developed. It came on stream as a national program in 2008. If you're serious about something, does it really take you 8 years to develop it? And then do you turn off the central funding 4 years later? I'd suggest not. So those are my 3 provocations. But I remain profoundly optimistic that this is a problem that can be solved. We have, after all, got, in the project manager's cliche, the burning platform for change. Indeed, in some ways surprising that there's any timber left to burn at this stage. What we need now are to apply the simple rules of change management which are as relevant to a small GP's clinic as they are to the largest employer in the land. We need clear, named leadership. We need a designated budget. We need change agents. We need the whole paraphernalia of cultural change. And we need to stick at it. It may not be the most exciting thing, but we must make sure that we're not distracted by the next passing fad or the next temptation for NHS reorganisation. I want to close with a cautionary tale. Again, I want you to imagine a scene, this time one in the future, 5 years in the future. And the new Secretary of State for Health has decided that she wants a white paper to mark her arrival in office. And consultation groups have consulted, strategy groups have strategized, working groups have worked. And the civil servant whose job it is to draft the white paper has begun to block out the principal chapters. There's one on public health, there's one on NHS reorganisation, Of course there's one on NHS reorganisation. There's one on new technology. And she thinks it would be a good idea to put to the minister a submission in her weekend box, giving a summary of what the executive summary of the white paper might look like. And she's got most of the component parts. She's just lacking one. So for inspiration, she looks back at her dog-eared copies of previous white papers, of previous NHS strategies, of previous 5-year plans. And eventually she finds it, and she completes the list. The last bullet says, good communication is critical to healthcare. We will launch a new initiative to drive up standards. Isn't it all too easy to imagine how existing initiatives will have fallen away in 5 years' time? How it will be launched as another token measure for funding only to be turned off shortly thereafter? The NHS deserves better than that. Healthcare professionals deserve better than that. The taxpayer deserves better than that. And patients deserve better than that. Thank you very much.